And now it's my pleasure to introduce you an excellent speaker, a distinguished member of University of Patras, Professor Kyriakos Kypreos, who is a clinical pharmacologist. And I think, Kyriakos, you will have a difficult work to improve some knowledge about the HDL cholesterol. It is well known that hypertension is a major risk factor for stroke, but dyslipidemia is the major risk for myocardial infarction and cardiovascular events. And on the other hand, the first lipidemic parameter in terms of intervention is LDL cholesterol. And after reaching the targets, we can proceed with the other lipidemic parameters. So I think that you are the most suitable person to clarify all this, and we're looking forward to enjoy your speech.
In fact, as you said, HDL is a very mysterious, as I'm going to say, lipoprotein, and it's always a challenge for all of us to investigate it and try to understand a little bit more about it. I have no conflict of interest to disclose. So as I said, HDL is very mysterious. Is there a pointer, or I can use the mouse? It's a very mysterious lipoprotein, and it appears that we know a lot about it, yet the more we learn about it, the more we realize we don't know much about it. So it's very frustrating, and as a matter of fact, a lot of us, all of us rather, who investigate this lipoprotein, we feel that we are somewhere in the Bermuda Triangle, where all efforts tend to get lost and away from success. So I think that this is the most frustrating part, but at the same time, very exciting, because it tells us that we can really know more and maybe capitalize on this lipoprotein. Certainly, HDL is not just a cholesterol. We like to call it a cholesterol because it's very easy, but cholesterol is just one component of this particle. There are other components as well: phospholipids, enzymes, proteins, and so on and so forth. So I would say that cholesterol is rather a biomarker that tells us how much of this stuff we have in blood, but it doesn't say anything more than just that. Because, as I said, numerous apolipoproteins are present, numerous enzymes, and they are all involved into different pathways. And so we heard about non-alcoholic fatty liver disease. We know that HDL has an involvement in non-alcoholic fatty liver disease. I'm going to talk today not about atherosclerosis that much, but about obesity and diabetes. And this is very surprising, because sometimes people are going to say, okay, well, how come HDL is involved in obesity and diabetes? But I'm going to show you that we have quite a lot of convincing evidence suggesting that it is an important factor in these processes, in these pathological conditions as well. Certainly, HDL it has different faces. It's multifaceted in the sense that you find it in spherical particles, in discoidal particles, in small particles, in large particles. So there is a lot of diversity, and this diversity has also to do with the backbone of the particle. So we may have, of course, apolipoprotein A1, which is the main apolipoprotein, which interacts with ABCA1, the lipid transporter, in different tissues. And through this interaction, we have the loading of lipids onto ApoA1. And eventually, once we have the formation of what we call the discoidal HDL particle, then through the action of enzymes, in particular LCAT, which is an esterase and esterifies free cholesterol and converts it into an ester, we have conversion of discoidal HDL into spherical HDL. And just to convince you that this is discoidal, you see electron microscopy analysis of these particles, which they look like stacks of disks. We also know, however, that different apolipoproteins can make different HDL particles. So apolipoprotein E, apolipoprotein C1, C2, C3, ApoA2, they all can make different HDL particles. So HDL is not just one single particle. It's a mixture of different particles. And what we also know is that this apolipoprotein backbone, to a great extent, thank you, to a great extent defines which lipids are going to be loaded onto this particle, and then whether the particle that will be formed will be antiatherogenic or going to be proatherogenic. Because it is surprising to say, and some people are caught by surprise when I say this, but we know that HDL is not always antiatherogenic, and under conditions it can be no atherogenic or proatherogenic in the sense that everything depends on the properties of these particles. So you may have a really protective particle, or you may have a particle that may not be functional, and this all depends on the type of lipids that this particle carries. I have been fascinated for the longest time by this very interesting correlation that I show you in this slide. And this is nothing more than just the definition, the classical definition of metabolic syndrome. We have visceral obesity, insulin resistance, hypertension. This is a meeting about hypertension. But at the same time, we have a very particular dyslipidemia. The dyslipidemia associated with metabolic syndrome has to do with increased triglycerides and low HDL cholesterol. And so I have been very impressed by the fact that the obese phenotype and type 2 diabetes, they tend to correlate to a great extent with low HDL cholesterol levels. So we were very interested to know precisely what is going on. But before I move forward, I would like to say that visceral obesity has to do with the accumulation of white adipose tissue. But at the same time, I want to remind everybody that we also have the brown adipose tissue. So of course, in an experimental mouse model that we use for our research studies, we have more brown adipose tissue. In human, we have some adipose tissue. It's very few brown adipose tissue. But in any case, white adipose tissue stores lipids, brown adipose tissue burns lipids. And so there are two structurally and functionally distinct types of adipose tissue. Here you see brown adipose tissue, brown adipocytes. They have a lot of mitochondria. They burn a lot of lipids. White adipose tissue, they have almost no mitochondria. They have a huge lipid droplet, and they store lipids. And the reason that white adipose tissue has been associated with metabolic parameters has to do with the fact that it interacts with many different tissues through a number of adipokines that have been secreted, and all these adipokines talk to other tissues in a paracrine fashion. In this way, we get these, I would say, cross reactivity between adipose tissue and different pathological conditions. And oftentimes, and this is something that is actively investigated by the pharmaceutical industry, there is an effort to convert white adipose tissue into brown adipose tissue by promoting the burning of lipids, by increasing the number of mitochondria, by promoting what we call the brownization of white adipose tissue and conversion it into bright tissue, which is a mixture of white adipose tissue with enhanced features of brown adipose tissue. And everything relies on this oxidative phosphorylation process that takes place on mitochondria, which either produces ATP or produces heat through the burning of fat. So you have a tissue, white adipose tissue, you stimulate it to make mitochondria, then it starts burning lipids for ATP production or for heat. And this way you can convert a fat tissue into a slim tissue. So the question that we ask ourselves is that how HDL may impact conditions like obesity and diabetes. And for all of you who happens to know me, we juggle between clinical research and basic research. And so now we went back to the basic research. We wanted to see what happens to the animal model. So we took an ApoA1 deficient mouse model that doesn't have any classical HDL. So this doesn't form HDL. And we also took an LCAT deficient mouse model that is capable of forming HDL, but it doesn't have the enzyme that will maturate this HDL and convert it from discoidal into spherical. So this mouse model has only discoidal HDL. And so we asked how these mouse models may be affected in terms of obesity. And so what we found is that even though wild-type mice gained some weight when they were fed a very high-fat diet, the mice that didn't have ApoA1 or they didn't have LCAT, they gain much more body weight. They became really obese. So if you don't have HDL, if you don't have mature HDL, then you immediately increase the sensitivity of the mouse to gain weight. And all this weight is basically visceral weight. And so when we isolated mitochondria from white adipose tissue, we saw that even though the control mice that have HDL, they were still capable of burning some of this fat through oxidative phosphorylation through the UCP1 protein. The ApoE1 deficient mice and the LCAT deficient mice, they were no longer capable of doing this. And that's why they were gaining more weight. This is very interesting because you would think that the lipoprotein in circulation would not have an impact on something that happens within the cell. But obviously this is happening. And if you don't have a fully functional HDL, then your white adipose tissue is no longer capable even of basic functions such as basic burning of lipids for production of energy. But we were very much interested. We were very much interested how HDL also affects glucose homeostasis. And maybe you are aware of the fact that recently different Mendelian randomization studies have proven a causative relation between HDL cholesterol levels and the risk of development of type 2 diabetes. And as a matter of fact, as we speak, different drugs have been that were used initially to boost HDL cholesterol, now tested for their anti-diabetic activity. So what we did is that we took the same animal models and we tested their sensitivity to exogenous administration of glucose through a classical oral GTT test. Oral GTT like this, and we found that the mice that didn't have the ApoE1, so the mice that could not form classical HDL, they had disturbed glucose tolerance even at baseline, even before they were fed Western type diet. When they were fed the Western type diet, then this became even much worse. And so it appears that if in the absence of classical HDL, the sensitivity, rather the homeostasis of glucose becomes much disturbed. This didn't happen though with the LCAT deficient mouse, and this was something very interesting because this is another experiment also disengaging obesity from glucose intolerance. So even both ApoE1 deficient and LCAT deficient mice, they become obese. Only the ApoE1 deficient mouse develops type 2 diabetes. And this is something that we also tested a little bit later because we took skeletal muscle from this mouse and we tested the capacity of this skeletal muscle to respond to insulin. And we saw that when we stimulate this skeletal muscle with insulin, the ApoE1 deficient mice, the mice that didn't have any classical HDL, were not able
to take up glucose. They were not responsive to insulin, something that was still possible with the control mice, and even with the mice that had discoidal but not spherical HDL. And when we isolated pancreatic beta islets from these mice, we also saw that the ApoE1 deficient mice, which did not have a classical HDL, I repeat, they had a blunted capacity to secrete insulin. So they didn't have the ability to secrete insulin in contrast to their wild type counterparts, or to mice that still had ApoE1 but could not convert it into spherical because there was no LCAT. So it appears that something happens if you don't have HDL. So we thought we struggle, as a matter of fact, to think how something which is in circulation may be affecting something so deep inside the cell, such as insulin secretion, insulin sensitivity, mitochondrial activity, etc. And we started thinking about plasma membrane, because plasma membrane is something that has been affected by HDL. And so we went to a good friend, Professor Molucci at the Catholic University of Rome, and we performed some biophysical analysis on plasma membrane, and we saw that the mice that didn't have ApoE1, they had a much more rigid plasma membrane on pancreatic beta cells. So, and sometimes I like to say that it's when you want to bring your hands together in the air, it's very easy. But if you want to bring your hands together in a swimming pool, or maybe in a pool of honey, I haven't done it, but I presume it's going to be very difficult to bring your hands together in honey, because of this rigidity that exists in the intermediate space. And so this is what is pretty much happening here. If you don't have HDL, the plasma membrane becomes very rigid. And when plasma membrane becomes very rigid, then you don't have proper function of surface receptors, including ion channels. And we know that for the secretion of insulin, ion channels are very important. Calcium channels, ATP-dependent potassium channels. And so if plasma membrane becomes very rigid, then you no longer have the ability to stimulate the secretion of insulin to the extent that you would like to. And this is a mechanism that explains why something like HDL, which is floating in circulation, may eventually affect the secretion of insulin. And recently, in a paper that we published in Depedologia, we're trying to explain precisely that there is an interrelation between dysfunctional HDL and type 2 diabetes and obesity, in the sense that type 2 diabetes and obesity may affect the functionality of HDL particle, which may further contribute to the deterioration of those conditions. So this is a self-feeding cycle where having the obese phenotype and type 2 diabetes, you have dysfunctional HDL will further contribute to type 2 diabetes and the obese phenotype, et cetera, et cetera, et cetera. But the question is, which came first? It's something that's very hard to address, but it's always a very interesting question, and we're actively investigating it. So coming back to the original question of my presentation, is HDL a guardian angel or an indifferent bystander? I think that it is a guardian angel. We have to improve the functionality. We don't have much tools at the present time, but I want now to move back to the clinical aspect of this presentation and remind everybody that the benefit of HDL in relation to its quantity appears to have a U-shaped curve. So if you have very little HDL or you have too much HDL, it can be equally damaging. So you have to have a an appropriate level, usually between, I would say, 45 to 70 milligrams per deciliter, where you can really see some the most of benefit. And maybe this is one of the reasons that all the approaches of raising HDL failed, because they took patients from very low levels of HDL and then shoot them straight to the very high levels of HDL. And that's why I think that all these clinical trials, they have to be redesigned by adjusting the dose of the medicines that have been tested. So if you ask me if CETP inhibitors failed, I would say that yes, they failed, but because of the design of the clinical trials that were shooting low levels of HDL to extreme high levels of HDL. I would think that these compounds, they need to get back to test, and we need to know more about it. But the question is how to raise low HDL-C levels. I think that it's relevant, it's very important how to raise HDL-C levels. At this point, we have only niacin alone or in combination with statins. We have omega-3 EPA, IPE, fibrates, and fibrates are very important because if we treat elevated triglycerides, then we can also raise HDL cholesterol levels. So this is something which is very important. There is an inverse correlation. If you have low triglycerides, then your HDL cholesterol is going to go up. And of course, increase physical activity, keep away from saturated fats, consume alcohol, and stop smoking. It is something that it is a lipoprotein that we need to know more. And the more we know, the more impressed we become. And we don't have much of pharmacological tools at the present time to make it possible for a very low HDL to be significantly improved. But also at the same time, I would like to say that oftentimes low HDL cholesterol may signify a very important underlying condition that needs to be treated. And currently we had a case of a liposarcoma, which was associated with very low HDL cholesterol levels. And when it was removed, immediately HDL cholesterol was reinstated back to physiological. So a low HDL cholesterol level should also be a bell ringing and indicating that something may needs to be addressed. There might be a problem, another problem that causes low HDL cholesterol levels. So I think that we're talking about the sleeping beauty of lipoproteins. I know there is a lot of hype about Lp(a), etc., but I think that we should not forget HDL. We know a lot about it, but we need to learn a lot more about it so that we can use it to the benefit of the patient. And before I close, I would like to thank all my colleagues all these years, because what I presented to you today is the essence of research that goes on the last, I would say, 15 years. And I want to thank all my colleagues in the lab, as well as in other laboratories, Anatol, Shlomo, Lukianos, and Giuseppe. And of course, again, I want to thank you, everybody here in the audience, and Professor Kotsis for giving me the opportunity to be here today and make this presentation. And you, Mr. Chairman, Professor Savopoulos, for chairing this session. Thank you.